Okay, what I'd like to do now is we had several questions there, and Stu, I know you wrote them down. Are those questions that you have answers for? And let's take it. The first speaker, Ms. Trigo, had a couple of questions.
And also there's
we'll go on with
three EMS questions. So okay. In the time I have, I'm the only one that has to leave. In the time I have remaining, let me hit the EMS issue because it's all right. One of my specialties, and then Dr. Milnes and Chief Myers can certainly talk about it. All the questions were exactly on point for a full fire master plan discussion. You'd have an EMS systems review. You'd have a deep type of call review to staffing outcomes and needs for not just medical but technical rescues and other things. So let me try to do in 3 minutes EMS Medical Economics 105, and it's crumbling under our feet as we stand here tonight. And let me explain 2 big reasons why. First of all, in America, you disagree with this term, but if you want, I'm going to use it. In America, we do not have medicine as a public good. If you go back to Economics 101, public-private good, medicine in America is private good. You pay for it. It's not your legacy right as a citizen to have, right, cost-free health care. We pay. America's had this struggle now for 100 years. In emergency medicine, medical reimbursement companies, insurers, Medicaid, Medi-Cal, called third-party payers, will reimburse only for ambulance transport because that's their lens of the world. Oh, they got the patient here, I'll pay them. In the last 30-plus years, as the American Fire Service got into EMS, because we had this reserve capacity, we're there to fight fires, but we have, quote, free time, let's do other public beneficial things, we got into doing EMS. It worked, right? As long as somebody could pay the bill for the advanced training, et cetera, et cetera. But much like fire insurance, and let me now draw 2 painful corollaries to the council. In America, why is the general fund paying for fire protection when the insurance investor on Wall Street benefits if you keep fire loss low? I understand the human, family, tragedy, emotion, but from an economics viewpoint, we're using general fund tax dollars to keep State Farm's payout low so the investor gets a better return on their State Farm stock. In other industrialized countries in the world, Australia, for example, 2/3 or better of the local fire department budgets coupled to the insurance industry in a cooperative relationship to enjoying the savings. That's the third rail almost of American Fire Service funding, and no one's ever been successful in touching it and decoupling or coupling this interest, much like in emergency medicine. So what we've evolved to by 2011 is, you've all seen the last 10 or 15 years, we've all felt it personally, what happened to American medicine? Managed care, right? HMOs. As HMOs were trying to squeeze the cost out of health care, they also squeezed the last bastion of red ink in HMOs was the emergency room. Why? Because as people fell ill or were underinsured, they called 911, went to the emergency room. So if you're in an HMO, and I'll pick on Kaiser because I are one, if I'm ill and I call 1-800-Kaiser nurse, what do I get? I get a triage call screening tree, and they're going to go out of their way, right? Anybody been through this? To get me a next day urgent appointment, right? They do not want me in the ER, nor do they want me in an ambulance that they have to pay for. So what's happening in American ambulance transportation is the payer mix that in my day, I'm an ex-medic, by the way, and I've supervised fire transport systems earlier in my career. In my day, we bill for city-based transport and collect anywhere from 66 to 75%, minus a smidgen for Medi-Cal that never did pay full load, and they don't today, don't begin to pay. Medi-Cal and Medicare don't begin to reimburse the full cost of an ambulance ride. So let's just say round numbers, we were getting 2/3 back on the dollar. The general fund was subsidizing that city ambulance by 1/3. We all knew it. And historically, I've testified before council saying, would you please raise the ambulance rates? Blue Cross and Blue Shield will pay more if you'd only raise the industry rate base. Oh, no, 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 we love keeping our ambulance rates low. That's fine. It's a direct general fund subsidy to Blue Cross and Blue Shield. Nowadays, the payer mix, we just completed 2 EMS audits. I'll give you 2 radically different descriptors in the country. Albany, New York, where 70% of the payer mix is state and federal aid patients who aren't fully paid for to begin with. Chula Vista, Southern California, and other California agencies have seen the payer mix fall to well under 50, if not under 40%, closer to 25 to 30% also. So if you're only collecting as an ambulance company, I'll be generous, 40 cents on the dollar, where's the other money come from? Well, as the big ambulance operations grew, the only way to make money was to do non-emergency interfacility transfers. Kaiser in this 9-county Bay Area marketplace moves almost more patients every day by ambulance than there are true 911 emergencies. Why? Because the patient's a just-in-time inventory commodity. You have a heart attack here, you're hospitalized somewhere in a Contra Costa Kaiser facility, but the clinician who needs to do your lab test tomorrow and is the best at exactly what you need, what's Kaiser do? They'll throw you in an ambulance and move you to San Jose. Kaiser's matching every day capacity, technology, and need to each individual patient. AMR and others make money moving those patients back and forth. That money subsidizes the 911 deficit I just described. So the last 10 years, cities got not out of, but deminimized the transport business because the big privates could operate on a much bigger footprint than a city limits and rake in the non-transport dollars to offset their deficit spending. That makes sense? As they did that, they did pay the fire service. In this county, in my home county, in Alameda, in most of the Bay Area, the big ambulance providers do give a rebate to the local EMS agency who pays the local fire department to offset their first response, fire truck, paramedic costs. Why? Because it's cost beneficial to AMR and anybody else in the multi-footprint, multi-county transport region, because they can have fewer ambulance hours on the street. If every little community wanted its own dedicated ambulance and you're only collecting 40 cents on the dollar, where's the money come from to pay for the other 60% of the ambulance crew? The city general fund? We're back in the subsidy game. So the big transport contracts were let to the private sector to get city subsidy totally out. So many of the larger city contracts and counties are what's called subsidy free. The ambulance operators given an exclusive operating area under state law. They get all the emergency and non-emergency transports, and hopefully it pencils black even for them, and they pay something to the fire service along the way. And chiefs, what's the current payment for a fire truck in this county? Okay, $30,000 per station per year is being EMS reimbursed to offset paramedic supplies, training, bioelectronics. So there is a cost quid pro quo there. So I said 2 things are shifting from under your feet. Number 1 was the payer mix has been eroding as America becomes more underinsured, and 911 is the healthcare last resort. So the big regional operators survive by offsetting with non-emergency. Where that no longer works, more than one private operator in the United States knocks on the door of local government and says you have a choice. Increase the public subsidy, or here's the car keys, I'm out of business. Game over. They have no choice. They're a for-profit private enterprise. If they can't make ends meet with the right payer mix, you don't have an ambulance service, or you're back in the public subsidy situation. Now, federal health care is restructuring what little is left of Medicare reimbursement. There's an article in our trade magazines now monthly. We're all nervous, like you're all nervous about the economy and RDA takings. I can't tell you today as a client what ambulance reimbursement will be under Medicare next year. If it lowers, trust me, Medi-Cal, the state of California, or Medicaid in New York, is going to lower. So the poor ambulance providers are increasingly stretched. Do they have enough non-emergent transfers to even keep their business in the black on 911? Because there's not enough Blue Cross Blue Shield left to pay the 911 bill. So I'm sorry for the long answer. If we were doing a full master plan, you would look at the payer mix, the current county-regulated EMS agreement with the regional ambulance provider, which exists in this county. State law prevents Pinole from going into the ambulance business by itself tomorrow. You could certainly request the regional system in a 3 or 4 fire district discussion to put an ambulance here. But trust me, AMR is only, or any company, I'm not picking on AMR, only puts enough ambulance hours in the street that are profitable. No more, no less. So if you want a dedicated ambulance in lieu of a fire truck, AMR is going to say, pay us the difference between what we can bill and collect versus you just having a standby 2-person ambulance in Pinole. Now, very quickly, in terms of tactics, why do fire trucks go with ambulances? Yes, it's true. On very simple calls, Johnny falls off the skateboard, twists his ankle, maybe it's broken, maybe it's just a bad sprain. Mom's understandably upset, calls 911. Could just a 2-person civilian ambulance take care of that call? Absolutely. If the dispatcher is guaranteed, that's all it is. Now let's turn the clock to Pa Kettle, who has a heart attack, falls off the bed, between the bed and the wall in the back bedroom of a motor home. And as typical of the common adults now in the United States, Pa Kettle's way too heavy. And he's either in a cardiac rhythm that's not perfusing blood or is in full cardiac arrest. I don't care who shows up, 2 firefighters or 2 AMR medics, 2 anythings. You can't get Pa Kettle out of the jam he's in physically, lift it out into the living room where I've got elbow space, and simultaneously and effectively open an airway, intubate, start an IV line, push drugs, hook up a cardiac monitor, and treat the patient. It is a minimum 4 to 6-person task to extricate a severely ill patient, treat them simultaneously, get them packaged and out to the ambulance. So the fire service provides that manpower, person power, excuse me. I'll date myself. Modern sophisticated dispatch systems on big footprints try to triage the calls to figure out the right mix of resources. And only send an ambulance sometimes only send 1 fire truck and an ambulance, sometimes to an auto accident send a fire truck, a ladder truck, a rescue squad, a chief, and an ambulance. So we do mix and match the resource headcount mix to the tasks to be done. But if you think my back bedroom analogy doesn't happen very often, next time you watch a medicine show, remember ER? Whenever they showed a trauma or a full arrest going in the trauma room, did you ever count on screen how many people are in that room? Seriously, go back and watch an ER rerun and count the heads in the room. That's not Hollywood. That's the head count it takes to put that many hands and do that many things simultaneously on that patient who's in risk of dying. So that's why so many people go. Is it a perfect system? No. Does it cost a few more gallons of diesel fuel and wear on the tires? Yes. But if you're paying for the firefighting standby capacity, why not send them into medical calls too? And that's what we've been doing for 35 years. As the counties rebid the EMS systems, hopefully we'll get more EMS payments through the county structured contracts. Those may dry up. We don't know what ambulance contractors will look like in 5 years. I'd be a fool to sit here and say I had that crystal ball. I don't. Right now, Alameda County and Santa Clara County just mammothly rebid their contracts and are bringing in new providers. I have no clue what the economic efficiencies of those contracts will be and whether the fire service payments will even be sustainable once federal health care restructures. That's EMS 101. That's why we go. That's why how many people. There's the economics. But that's where a master plan, not a consolidation feasibility study, would help the community answer those questions. We heard about differences in drivers culturally. Chief Myers has lived through it. Dr. Millens has lived through other interagency things, and with my apologies, I'm going to scoot to Belmont tonight in the Belmont-San Carlos feud that you've probably read about in the paper. But certainly we can address that there are key differences in drivers, and a regional partnership study has to look at local commonality. And I would say in this county, for example, studying West County and Discovery Bay, Brentwood et al. Is a bridge too far. You don't have commonality of community, civic interest, ability to pay, what kind of fire and EMS services you want. So a county-wide single department study would be pretty tough to get so many diverse little population groups on the same page. Could you do it West, Center, and East County, perhaps? Maybe what we're going to figure out with LAFCO is maybe it's 5 or 7 contiguous pockets of common philosophies, and that's what you design your safety services on, because you all see eye to eye, in the West County. So that's another quick thing on commonality. Thank you.
Okay, thanks very much, Stu.
Mr. Mayor, could I add just a few comments to what Stu was talking about?